Hi, I'm Jaime Sanders. I'm a professional advocate and a member of CHAMP and the Headache Migraine Policy Forum. I do want to update my conflicts of interest. I have received compensation and travel for patient advocacy events, and as a member of CHAMP and a member of the Patient Leadership Council sponsored by the National Headache Foundation. So, good afternoon. Thank you so much for inviting me here to speak today regarding acute treatments for migraine. I stand before you today, a 41-year-old woman who lives with daily intractable migraine. Since the age of 8, migraine has been a constant part of my life. Unfortunately, pain has been something I have become too familiar with over the years. As time drew on, episodic migraine became chronic, then intractable. Through this evolution, I have needed and used many preventives and acute medications to treat my disease and symptoms. On my journey with migraine, I have found that I am allergic to sumatriptan, which causes anaphylactic shock, and I cannot tolerate any of the other triptans. I have an allergic reaction to many NSAIDs and cannot tolerate DHE when administered at home, either by injection or nasal spray. The pain management options I am left with are extremely limited. And while I also live with anxiety and depression, this reality only exacerbates feelings of hopelessness and defeat. Despite quarterly Botox injections, bilateral occipital, supraorbital, and sphenoganglion blocks, acupuncture, massage therapy, and 4 preventive medications, I am still in pain every single day. My acute treatments are simply Toradol, Compazine or Zofran for nausea, and Thorazine to sleep off the really bad attacks. And I really limit and reduce how often I take that because I don't want to risk chronifying more my already chronic condition, and to reduce medication overuse headache. And I have to pay out of pocket for ketamine nasal spray as my rescue medication, which is about $90 per month, and I have to have it shipped from a compounding pharmacy out of state. When all of those fail me, I can take a steroid taper, but 95% of the time it just interrupts my sleep and eating patterns. More often than I prefer, I find myself in my local urgent care center getting a very specific treatment protocol written up by my headache specialist due to long bouts of intractable migraine. If that also fails, the next step is to be admitted in the hospital for DHE infusions, which could take up to 3 days. Not only is this a huge burden on me physically and emotionally, it deeply affects my family. In order to care for me, my husband needs to take off from work days at a time. My children see their mother unable to function most days. The hours and days spent in urgent cares and hospital rooms are times I cannot get back. My life with migraine could change drastically with these new acute medications for migraine. I now have a viable pain management option that could potentially work for me, unlike the triptans. I am barely getting by on my current regimen and need something better. It is disheartening that ICER finds these new therapies to be less effective overall than triptans. In your report, you consider the evidence on all 3 acute medications compared to placebo to demonstrate a moderate certainty of a small or substantial health benefit and a high certainty of at least a small net health benefit for adults with moderate to severe migraine attacks that have not responded to non-prescription medicines or for whom triptans have not been effective, are not tolerated, or are contraindicated. I find this to be concerning because it could mean that for someone like myself who is allergic to and cannot tolerate triptans, there is a real possibility that I will not have access to any of these new therapies. Since these outcomes are mostly based on limited trial data and the use of QALY, or quality adjusted life year, the decisions based on those outcomes can adversely affect patients. Methodologies used to measure values, such as the QALY, rarely evolve enough to truly provide the strongest view of the therapy's value. Many therapy value analyses take place around the time of marketing approval. Nonetheless, applicable research pertaining to the treatment, the disease it addresses, and other therapies are still emerging. Also, this collection of facts over time gives the clearest interpretation of the value of a treatment. QALY can also discriminate against people with disabilities and serious chronic conditions. To measure the extent to which a treatment extends life and improves health, a QALY analysis uses a weight factor known as a disability weight that reflects the severity of the disease on a scale from 0, perfect health, to 1, equivalent to death. These disability rates reduces the value of life-sustaining properties of a medication if it is not also possible to return a patient to full health. For someone like myself, a drug may not seem valuable to cover due to my diagnosis of chronic migraine, which on the Migraine Disability Assessment Test, my score would reflect a level of moderate to severe disability. There should be a sufficient integration of the tangible benefits of good health, including considerations related to quality of life, such as being able to physically carry out a task or attend an event or meeting, as well as having the mental well-being to interact with family or friends at work or in community activities. Overall, the impact these value assessments have on patients is extremely monumental in how we can live quality lives. Patients are put in situations where they are rarely in control of their own health care due to the interference of insurers by way of value assessment frameworks that poorly balances their evaluations with a comprehensive consideration of benefits to the patient. Patient input, updated use of qualities to also address disabilities and chronic conditions, and proper representation on the voting panel to include clinical experts who are within the medical specialty they are assessing are strongly recommended. It is my hope that through the engagement of patient advocacy groups and their regional platforms like social media, the inclusion of patient voice will be a permanent piece of future value assessments. Thank you.